Hi everyone, very warm welcome to all of you guys. Let me know, first of all, let me know whether I'm clearly audible and visible. I know last time we had some issues with the audio. Saloni Awaz, are you able to hear me? Let me know. Good evening, Hari. Good evening, Puneet. Good evening, Saloni. Are you guys able to hear me and see me? Just do let me know so that we can proceed for the session. Remaining questions of physiology we will be doing today, right? In the last class we had some questions, so we will be completing all the things today. Hello Sachin. Good evening. Good evening. Okay, so let's begin. So today we are going to cover up the next questions in the list that we are having. We will be doing these things today. So yesterday we have seen in the last class we have seen certain things. Now we will be discussing from this particular question, right? We are done with the diabetes. No issues with this. No issues with this. Last class what we have discussed. Perfect. Right. So let's try to solve the next question in the list. Next question, we are having a 28-year-old male patient, and this particular patient had a road traffic accident. This is a case of RTA, and because of the road traffic accident, what was happening to the patient? He had to undergo certain kind of surgeries, right? And onto that surgeries, what was happening? We have to remove the ileum and jejunum. Maybe we are doing iliojejunostomy, right? We are doing some resection and anastomosis, right? And this thing is getting resected, and now which deficiency they wants to know. They want to know which deficiency this particular patient is going to have. So this is going to be a physiology question. They are going to give you some history from the surgery. They are going to give you some clinical scenarios, and they want to know which part of the intestine is going to absorb what. This is a physiology question, right? So no, Puneet, no, this is not iron. In last class, we have discussed in detail about iron. Iron is going to get absorbed from the duodenal mucosa. This is what I have taught you. Iron is going to get absorbed from the duodenal mucosa. There is going to be DMT, divalent metal transport, right? So this cannot be the answer. It is not going to be the answer. It is not going to be the answer. Okay, so let me discuss what are the different things that are going to get absorbed from which different parts of the body. So let me make you understand the complete story. Whatever things you are eating from the beginning, we are going to start from the scratch. Whatever things you are eating, that is going to go into your mouth, then it will be going to your esophagus, then it will be going to your stomach, then it will be going to your duodenum, then jejunum, then ileum, then a colon, ascending, transverse, descending colon, sigmoid, and then ultimately it will be going out. Now, most of the things, listen to me carefully, most of the things will be getting reabsorbed. Most of the things will be getting reabsorbed in the duodenum and jejunum. Duodenum and jejunum, most of the things. If you don't know the answer, you can go for the duodenum, right? So, what are the things that are going to get reabsorbed in the duodenum? Remember folic, remember iron, remember calcium. All these things are going to get reabsorbed in the upper part. It is not going to go till ileum, right? And in this particular patient, we are doing what? Ileum and jejunum surgery, right? Remember this duodenum. Let me write it down for the duodenum first. Duodenum is going to be responsible for most of the things will be getting reabsorbed here. Most of the things are going to get absorbed here, right? After duodenum, there will be jejunum. There will be jejunum. This was your exam question, previous year question. Jejunum is going to absorb a lot of water. It is majorly concerned with the absorption of water. How much is that water it is going to absorb? Remember, in your body you will be having total 9 liter of secretions. Along with the fluid intake that you are doing in your alimentary canal, you will be having total 9 liter of secretions from different glands, right? 2.5 liters from HCl is coming from GIT, 1.5 liter of saliva is coming from the mouth in a day, right? Likewise, this jejunum is responsible for the maximum water reabsorption. Maximum water absorption, 5.5 liter, approximately 5.5 liter. This was your PYQ. 5.5 liter of water is going to get reabsorbed from the jejunum. That is going to be responsible for the reabsorption. Last part we are having is ileum. Remember this ileum, two important thing I want you to remember. One is your bile salts, and second one is your vitamin B12. Vitamin B12, when binding with the intrinsic factor from the parietal cell, intrinsic factor is coming, right? It is going to bind with the parietal cells, it is going to bind with the intrinsic factor, and then it will be going to the terminal ileum, and there it will be getting reabsorbed, right? So if someone is having surgery of ileum or problem with the ileum, two things can happen. One is vitamin B12 deficiency. Second thing is going to be something is wrong is going to happen with the bile salt reabsorption. That is going to be your enterohepatic circulation that we have discussed, right? So whatever things you are eating, it is going to get reabsorbed mostly in the duodenum. Let me make you understand what are the different things that you are eating. We are eating what? We are eating carbohydrates. Suppose you are eating rasgulla. What is going to happen with that rasgulla? Let's try to understand. In your mouth you are having saliva will be having an enzyme that is going to be salivary amylase. So whenever you are going to discuss about any kind of amylase, it is going to be responsible for the carbohydrate digestion beta. ठीक है, तो जब भी amylase की बात होगी, so it is going to digest what? Carbohydrate. So we are having carbohydrate digestion in mouth with the help of salivary amylase. Then this carbohydrate is going to the, after the mouth, it is going to the stomach. In stomach, remember, there is no enzyme for carbohydrate digestion. In stomach there is no enzyme. There is no enzyme for carbohydrate digestion. There is no enzyme, so there will be no digestion of carbohydrates in the stomach, right? After stomach, it is going to go to your duodenum. It is going to go to your duodenum. Your duodenum will be having opening of pancreatic duct. It will be having pancreatic amylase. So duodenum will be having carbohydrate digestion, right? Remember, as far as this GIT chapter is concerned, it is always concerned with the digestion and absorption. Two process. Digestion means whatever rasgulla you are eating, it is going to make what? Glucose. So this process is known as digestion. And second process that we are having simultaneously, that would be your absorption. That glucose will be going into your blood vessels, causing hyperglycemia. And in the last class, we have seen how this hyperglycemia is happening, right? So the question they can ask you, there is no digestion of carbohydrate in the stomach. What about fats? Remember, in the mouth we are having lingual lipase. Lipase is responsible for the lipid digestion. So mouth, there will be digestion of lipid. Okay, in the pancreas there will be gastric lipase. So it is going to cause digestion in the stomach as well. And in the duodenum you are going to have pancreatic lipase. So in duodenum also there will be digestion of fats, right? So all three things will be getting digested. Second question they ask you is about the proteins. So remember, in the mouth you do not have any enzymes for protein digestion. So mouth, there will be no enzyme for protein digestion, so there will be no digestion of protein in the mouth. In the stomach you are going to have what? Pepsin coming from the chief cells will be releasing pepsin and lipase. Two things will be there, right? So in the stomach you will be having digestion of proteins. Yes, and lastly we are having duodenum. In duodenum you are having trypsin, chymotrypsin, all these enzymes, so you will be having digestion. So two questions they can ask you. First question, there will be no digestion of carbohydrate in the stomach. Second question they can ask you, there is no digestion of protein in the mouth. There is going to be no digestion of the protein in the mouth. Puneet is okay, let me make you understand. What is this function of this bile? So whatever fats you are eating, let me give you simple explanation. Whatever fats you are eating, Remember, carbohydrates we have seen. So suppose these are your fat particles that you are eating. It is in your GIT. It is in your stomach, right? Now it is in your duodenum. Now it cannot cross the barrier because it is also a lipid. It is a lipid. It cannot cross the barrier. So what is going to happen? Bile is going to come from the liver. It is going to come from the gallbladder, and it is going to do emulsification. What is this emulsification, sir? It is going to make a covering around it, right? This is known as emulsification, and this is the function of bile. Now what is going to happen? This emulsified fat can transport to the blood vessel. Remember, here will be cells, and here this is your blood vessel. This is going to be your blood vessel. Now what is going to happen? This bile is going to drop all these fat particles into the blood vessel. Now these fat particles are going to come into blood vessel, and this bile is going to come back. This bile is going to come back into the blood, and this is what is enterohepatic circulation I'm talking about, right? This thing is happening at the level of ileum. This thing is happening at the level of ileum. So whatever fats you are eating, they are going to go throughout your GIT. They will be binded with the bile. Bile will be transporting those particles by micelle formation, by emulsification, and these micelles will be coming back. These bile acid will be coming back via enterohepatic circulation, and these are the fat particles that will be in the blood vessel. Now these fat particles, you have studied about lipoproteins. Very good. So lipoproteins are lipid plus protein. Lipid plus protein. So these lipid particles are going to bind with the proteins. What are your lipoproteins? Chylomicron, LDL, HDL, VLDL, IDL. All these are your all these are your lipoprotein. They are going to pick this particular fat particle, and it will be traveling, right? Now it has become what? Now it will be making what? Fat plus lipid. They are going to become what? Lipoproteins, and these lipoproteins will be traveling around the body. You understand? So if you want to if you understand this particular thing, suppose this bile is not coming. Some patients are there which are having what? A specific disease. Suppose there is problem with the bile. Suppose there is problem with the liver. What is going to happen? This particular fat particles, do you think they are going to come into blood vessel? No, they are not going to come into blood vessel. They are going to go out through the rectum, and this particular thing is known as what? I want your answer. This particular thing is known as what? The fat particles are going out into the stool. What is this particular thing is known as? Yes, Priya, Puneet, Kiran, please try to answer. What is this particular thing is known as? If fat particles, if someone is having liver pathology, someone is having bile pathology, what is going to happen? Someone is having problem with the ileum. There will be this particular thing will be going out. This particular thing will be going out, and this is known as what? This is known as, yes guys, this particular patient will be having, very good, Sunit, that is going to be steatorrhea. This particular patient is going to have what? Steatorrhea. Very good. You understand, this is the basic physiology. If you understand physiology well, there is nothing about like medicine, and everything will be easy for you, right? So this is the patient who is going to present with the steatorrhea. Suppose a patient is coming to you now with the steatorrhea. You will be thinking in the terms of bile disease pathology. You will be thinking in the terms of liver pathology, right? So what is happening? You understand this, right? And this particular patient will be having this symptom, right? So what is going to be your answer in this particular case? Your answer in this particular case is going to be your bile salts. Bile salts are going to be deficient in this particular patient because of the resection of this particular thing, right? Is that okay? No issues with this? Should we move to the next question? So the next question is in front of you. Try to read and try to answer. A 26-year-old male patient met a road traffic accident. Again, there is a RTA patient that leads to an injury in the inferior frontal gyrus. This particular patient is having injury in the inferior frontal gyrus, and which is the area that is going to involve? Area number 44, right? Leading to aphasia. What is happening with the patient? Patient is having what? Aphasia. Patient is having what type of aphasia? Whenever there is lesion in the inferior frontal gyrus. If any patient is having lesion in the inferior frontal gyrus, if there is problem with the frontal lobe, let's try to understand what kind of lesions you will be finding over here. So there are going to be certain kind of lesions. First one, Broca's area. If Broca's area is present in the inferior frontal gyrus, left inferior frontal gyrus, this is the This is the location for Broca's area. What is going to be the area number? Area number 44 and 45 will be involved, and this is going to be concerned with the motor speech. It is going to concern with the motor speech. Whatever I'm speaking, that is going to be motor, right? Whatever I'm hearing and sensing, that is going to be sensory speech, right? So this particular patient is going to have what kind of aphasia? This particular patient is going to have Broca's aphasia or non-fluent aphasia. This particular patient is having difficulty in speaking, right? He will be having difficulty in speaking. He is not able to get the words out properly, right? This is going to be the symptom whenever there is going to be injury to the inferior frontal gyrus. It can be due to road traffic accident, it can be due to any other reason, right? But the problem will be same. So we will be looking at the patient, we will try to talk with the patient, and we will understand patient is not speaking well, right? What is the problem? We will think the problem lies in the inferior frontal gyrus. What is gyrus? So we are having gyri and sulci, that is going to be depression and elevation in the brain. So this is going to be present in the frontal lobe. Yes, very good, Chintu, very good, Puneet, Yuga, Priya, right? So you guys are answering well. Next, what is Wernicke's aphasia? What is Wernicke's area? So remember, if the problem lies in the superior temporal gyrus, or they are writing in the question area number 22, this is a previous year FMG question, right? NEET PG, they have also asked. This is a high yield topic, right? So if there is problem in the superior temporal gyrus, or they are giving a history, patient is having some stroke or something like that, and the patient is having problem with the understanding, or problem with the sensory type of speech, right? This is going to be your area number 22, and this person is going to have sensory type of aphasia, and this is known as fluent type of aphasia. The patient can speak, right? This is your Wernicke's aphasia. Two things you have to remember: the area number will be 22, and this person will be having superior temporal gyrus injury, right? Here the patient will be having fluent type of aphasia. This person is going to have issue with the understanding, right? Here in Broca's, the patient will be speaking, he will be speaking, but he will be trying to speak, right? But he is not able to get the words out, proper words out, right? What will happen in the arcuate fasciculus injury? If there is injury to the arcuate fasciculus, they are going to attach both the Wernicke's area and also this particular Broca's area, right? So what is going to happen if there is going to be any injury? If there is going to be any injury, this particular type of aphasia is known as conduction aphasia. Here the patient will be having difficulty in repeating the words. For example, let me give you example. So let's say if I'm talking like this is a pencil, so once I'm calling it pencil, next time I will be calling it pankil or something like pakil or something. I cannot get the right word out. This is type of conduction aphasia. This is the thing you will be finding in the patients, right? So here you will be having difficulty in repetition. Here you will be having difficulty in repeating the word. And lastly, we are having angular gyrus injury. If there is injury to angular gyrus, this is the area which is going to connect with the visual area with the speech, right? And if there is injury, what is going to happen? You will be having anomic aphasia. For example, let me give you one example. Let's say this is an apple, right? If I'm showing the patient apple, what this patient is going to perceive, he is going to tell you this is something just like a red thing, or you are using this particular thing to make something, but he's not able to pronounce it as apple. This is going to be anomic type of aphasia. This patient is not going to name it correctly. This is going to be your anomic type of aphasia, right? So these are going to be the aphasia. Here the question has given area number 44 or 45. Frontal, remember frontal is going to be Broca's aphasia. If there is going to be temporal involvement, there is going to be your Wernicke's aphasia. So here the problem lies in the inferior frontal gyrus, area number 44. What would you think? What is going to be your answer? What is going to be your answer if it is going to be area number 44, inferior frontal gyrus? The problem lies in the inferior frontal gyrus, area number 44. Yes, this is going to be 44. 44, 45, this is going to be what? This is going to be Broca's. Okay, this is going to be Broca's aphasia. This is going to be your Broca's aphasia. Next in the list, we are having question. 76-year-old male patient is presented to the emergency department with the symptoms of stroke. Patient is having what? Stroke. On examination, doctor is performing certain test and the test is coming out to be positive, right? And all of the following can be feature of this particular thing except. So what this question is trying to ask, what is the thing they are going to ask you, and the test they are doing, this is known as Babinski test, Babinski reflex. The test they are doing is Babinski reflex. So what is going to be your answer? Yes. So this is a question about upper motor neuron and lower motor neuron palsy, right? This is a question about lesion in the upper motor neuron or lower motor neuron. Let me make you understand what is that upper motor neuron and lower motor neuron. First of all, let me make you understand how the information from the below part of the body is going to the brain and how the information from the brain is coming to the effector organs that we are having, right? So let me just I'm just taking a cross section of the spinal cord and presenting in front of you. Okay, so what I'm doing, I'm just taking a cross section of the spinal cord and presenting in front of you. This is going to be the cross section of the spinal cord. Suppose these are your spinal cord. This is your spinal cord. We are having, this is your central canal. So we are having three things over here. We are going to have what? We are going to have what? We are going to have three pathways. We are going to have three wirings. So this is your anterior part, this is your anterior part, this is your lateral part, this is going to be your dorsal part, right? And in this particular spinal cord, what is happening, all the information from the body will be going to the brain, and from the brain all the information will be coming via this, right? So now we are having wirings, just like that we are having wirings. So there will be wiring that will be going up, whatever things you are going you are taking up from the lower part of your body or from your body, whatever sensory impulse that are going to your brain, this is going to be your spinothalamic pathway. Spino means from the spine to the thalamus, from the spine to the thalamus, that is going to be your spinothalamic pathway. So we are taking information from spinothalamic pathway, and then we are having corticospinal pathway. Cortico means from the cortex the information is coming to the external organs or the periphery, that is going to be your corticospinal pathway. So how this wiring is going to go up, so remember, we are going to have this dorsal, this lateral, and this anterior. These things will be going will be taking the information upwards. So information कहाँ से जाएगा? Lateral spinothalamic tract will be there, anterior spinothalamic tract will be there, dorsal spinothalamic tract will be there, but the information will be coming via only two pathways. One is your lateral, another one is your anterior. So corticospinal tract दो ही होंगे. First one is your lateral corticospinal tract, second one is your anterior corticospinal tract. So what are the information that are going to go, okay, and what these things are going to be responsible? So you can remember lateral. So lateral का मतलब क्या है? लात पड़ेगी. You can remember like that. What is going to happen whenever you are going to have a kick? लात पड़ेगी तो क्या होगा? Pain and temperature. So remember, lateral pathway is responsible for taking the pain and temperature sensation to the brain. Second one we are going to have is anterior. Anterior auntie or aunt, you can remember. So what is going to happen, this particular thing is going to be responsible for the crude touch, aunt ka touch, crude touch, and pressure will be there, right? So aunt will be responsible for the crude touch and pressure. And then we are having this dorsal pathway, dorsal column pathway. The information from the dorsal column pathway is also going. Two nucleus you have to remember here. One is fasciculus cuneatus, second one is fasciculus gracilis. So you can remember, we are having gracilis and we are having cuneatus. So we are having cuneatus and we are having gracilis. Remember, this cuneatus is having EAT, eat, right? So what it is going to be responsible for? Eat किससे करते हो, खाना किससे खाते हो, हाथों से, right? So it is going to take information from the hands, upper parts, and this gracilis or race, you can remember race कहाँ से करते हो, legs से. So you can remember this is going to take information from your legs. What information they are going to take? Simple. They are going to be responsible for the fine touch. They are going to be responsible for the fine touch. They are going to be responsible for the proprioception, 2-point discrimination, vibration, right? So all this information is going to be taken up by these pathways. Okay, so information from the lower part of the body, question they will ask you, crude touch is taken up by anterior pathway. Lateral is responsible for, lateral spinothalamic tract is responsible for pain and temperature, right? And antivala, that is going to be your crude touch and pressure, right? All this information from the spine, from the periphery to the spine, from the spine they will be going to the thalamus. All this information is going to go to the thalamus, and thalamus will be having like ventro-posterolateral nucleus of the thalamus. This is going to be a relay station. So all this information is going to go to thalamus, and from the thalamus this information is going to go to the somatosensory cortex, and that is going to understand कहाँ पर पेन हो रहा है, कहाँ पर टेम्परेचर लग रहा है, कहाँ पर क्रूड टच है, प्रेशर है, फाइन टच है, वाइब्रेशन है, एवरीथिंग it is going to understand. If you understand this, then there will be some lesion. You will be easily understanding what is going to be lost. If there is some lesion, like we discuss about we are going to discuss about some lesions, like you are having injury due to knife, there will be a syndrome. What is going to happen? There will be a brown sequard syndrome. What is going to happen? If you understand the pathway, everything will be easy for you, right? So this is the spinothalamic pathway in a brief, right? Now I'm going to talk about the corticospinal pathway. Now information from the above will be going to come below, right? So this is your corticospinal pathway, and two types of neurons will be there. One is upper motor neuron, second one is your lower motor neuron. So information from brain is going to come over here. Okay, this is going to be a part of upper motor neuron, and from here, from the spinal cord to the body, that is going to be your lower motor neuron. So let me make a note for you. So what is going to be upper motor neuron? Upper motor neuron, remember, it is going to start from the cortex, and it will be going to cranial nerve nuclei in the brain, and also it will be coming to anterior horn cells of spinal cord. So it will be whatever this yellow structure that you are looking at, this is going to be your upper motor neuron. From the anterior horn of spinal cord, that is going to go to the peripheral nerves. So this is going to be your lower motor neuron. So from the anterior horn cells to all the peripheral nerves, to motor end plate, to the effector organ, motor end plate, this is going to be your lower motor neuron. Right? And this test that we are performing in the hospital, this is known as Babinski test. If the patient is coming with a stroke and we want to identify whether it is upper motor neuron lesion, whether it is a lower motor neuron lesion, right? How we can assess for that? We are going to take any sharp object, like you can use keys, you can use something like that, right? So any sharp object, and you are going to do this type of movement. What is going to happen? There will be flexion, there will be extension. If there is extension, what is going to happen? This is going to be positive, and this is going to be positive in the which kind of lesion? This is going to be positive in the upper motor neuron palsy. This is how we are going to understand whether the lesion is in the upper motor neuron, whether the lesion is in the lower motor neuron. You will be performing this particular test very commonly when you do the internship. Every patient is coming, you are going to check whether it is upper motor neuron lesion, whether it is lower motor neuron lesion, right? So what is going to happen? Another thing, there will be some hierarchy. If you understand, upper motor neuron is going to activate your lower motor neuron, and now this lower motor neuron is going to work on the muscles. So it's like a system that we are having. Upper motor neuron is going to tell the lower motor neuron, and now this lower motor neuron is going to contract the muscle. So what is going to happen? What are the symptoms you will be finding if there is upper motor neuron lesion and lower motor neuron lesion? I'm going to make it very simple for you. Okay, just look at this particular thing. If there is upper motor neuron lesion, if there is upper motor neuron lesion, just think it like a boss. So if there is no boss, if there is no boss, what is going to happen? These are the workers, these are the workers, or these are the people who are working, right? What they are going to do? They are going to get hyper activated. If there is no boss, what is going to happen? What will happen to the tone? Tone will be increased. What kind of paralysis you will be having? You will be having spastic type of paralysis. देर विल बी हाइपर एक्टिविटी, सब कुछ बढ़ जाएगा अगर अपर मोटर न्यूरॉन लीशन नहीं है, मतलब बॉस नहीं है. सो एवरीवन विल स्कैटर, राइट? एवरीवन विल वर्क फास्ट. व्हाट विल हैपन टू द डीप टेंडन रिफ्लेक्स? दे विल बी एक्सग्रेटेड, दे विल बी increased. Deep tendon reflex will be increased. What will happen to the Babinski? Sir, Babinski will be coming positive here. Babinski will be coming positive here if there is upper motor neuron lesion. What will happen if there is lower motor neuron lesion? अगर लोअर मोटर न्यूरॉन नहीं है, अगर जो बीच में काम करने वाला है वो नहीं है, व्हाट इज गोइंग टू हैपन? दिस बॉस इज हैज नथिंग टू डू विद द मसल. ये बॉस तो जाके इनको नहीं बोलेगा, बॉस तो जाके लोअर वर्कर्स को नहीं बोलेगा अगर मैनेजर एब्सेंट है. सो व्हाट इज गोइंग टू हैपन? दे आर गोइंग टू कॉज, there will be decrease in the work, there will be decrease in the tone, there will be what kind of paralysis you will be having? Flaccid type of paralysis. What will happen to the reflexes? Now sir, reflexes will also get decreased. Deep tendon reflex will also get decreased, or maybe they can be absent. You will be doing the reflex, maybe they can be absent, right? And what will happen to the Babinski? It is going to come negative, it is going to come negative. I hope you understand what will happen. So you can think it like that also, right? Upper motor neuron is the like classes, right? Just think it like that. So it is going to be boss, it is going to be your HR department, and this is going to be your workers, right? So if you understand it like that, what is going to happen? Everything will be easy, right? So if there is no boss, what will happen? They will be causing the overactivity. ये boss बन जाएंगे. But अगर HR नहीं है तो boss is not going to interact with the workers directly. Okay, ये अपने हिसाब से आराम से रहेगा. There will be decrease in the tone, there will be decrease in the reflexes. सब कुछ कम हो जाएगा, right? You understand this? Okay, so now try to answer this. What is going to happen? This particular patient is having Babinski positive. You understand what kind of question they want to ask? This particular patient is having Babinski positive. This is your PYQ question, right? This particular patient is having Babinski positive. If Babinski is positive, that means what kind of lesion is this? Is it going to be your upper motor neuron, or is it going to be your lower motor neuron lesion? Yes, it is going to be, very good, this is going to be your upper motor neuron lesion. And if it is upper motor neuron lesion, what is going to happen with the tone? Sir, everything will be increased. Upper motor neuron मतलब boss नहीं है. What is going to happen? There will be hypertonicity. There will be what kind of paralysis? There will be spastic type of paralysis. What will happen to the deep tendon reflex? It will be increased. What is the odd one out? What is the odd one out? The odd one that is out is your flaccid paralysis. Flaccid paralysis, right? You understand this? You understand this type of question? If they ask you, I hope you will be able to solve this type of question as well, right? Next question in the list we are having, testosterone is secreted by. Testosterone is secreted by. Let me know if you guys are understanding this type of question. You will be able to do. Yes, Sunil. So you are answering D. Yes. Now for the last question it was D. Okay. For this particular question, what is going to be your answer? Testosterone is secreted by. Remember, in a male person, you have to think in the terms of two things. Rest female you will be studying in Ops Gynae, but male it is concerned with me, right? I will be teaching you. So what is going to happen? We are going to have two cells. We are going to have, whenever I'm going to talk about the male person, I'm going to talk about the Sertoli cells, I'm going to talk about the Leydig cell. I'm going to talk about the Leydig cells and Sertoli cells. What this Leydig cells is going to do, remember, whenever there are formation of testes, testes will be having two things. First is your Leydig cell, second one is your Sertoli cell. This Leydig cell is responsible for the production of what? Testosterone. Under the influence of LH, it is going to make what? Testosterone. And now this testosterone is going to make, if I talk about a baby, this is going to make what? Internal genitalia. Remember, the internal genitalia of a person is concerned with the testosterone. And this internal genitalia is what? It is going to make which duct? This is your anatomy question. It is going to make a duct that is going to be your Wolffian duct, and this is going to make internal genitalia. Mnemonic is seed, seminal vesicle, ejaculatory duct, epididymis, and vas deferens. So this is going to be your internal genitalia because of testosterone. Now this testosterone is going to convert into dihydrotestosterone with the help of a certain enzyme. What is this particular enzyme? I hope all of you know this. This is going to be your 5-alpha reductase. And this dihydrotestosterone is going to make what? It is going to make, sir, external genitalia. It is going to make external genitalia. So growth of penis, growth of testes, growth of prostate is concerned with what? It is concerned with dihydrotestosterone. It is not concerned with the testosterone, right? This is going to be more potent thing, right? And we are also using 5-alpha reductase inhibitors, right, in the cases of alopecia, right? So what will happen with the Sertoli? Yes, very good, Puneet. It is going to release the most important thing, that is going to be your anti-Mullerian hormone. That you have to remember. Mullerian inhibiting substance or anti-Mullerian hormone is coming from the Sertoli cells. These are known as nurse cells. The important ones I'm talking about, this is going to be responsible for the phagocytosis of the dead sperm cells, right? And it is going to make blood testis barrier. Which is going to have what kind of junctions? Remember, I taught you claudine and occludine tight junctions. In this video itself, I've told you in the part 1. Right? So this is the important things about Sertoli cells. It is going to make anti-Mullerian hormone, which is going to inhibit Mullerian duct, because Mullerian is going to make female organs, right? So Sertoli cells is going to inhibit that female organs. Otherwise, what will happen? The person will be having both male and female organs, right? That you understand, right? Second thing, we are having the function. This is going to be the nurse cells, and it is going to be responsible for the phagocytosis and blood testis barrier, right? This FSH and LH, these are going to be coming from your anterior pituitary. They are going to come from anterior pituitary. Basically, what is happening, let me give you the complete story. What is going to happen? Your brain will be releasing what? Gonadotropin releasing hormone, and this gonadotropin releasing hormone is going to go to the anterior pituitary, and now your anterior pituitary is releasing what? First is your FSH, follicular stimulating hormone, and second one is your luteinizing hormone. It is going to come both in the male and also in the female, and this GnRH will be having a specific type of release, that is going to be your pulsatile release. Whenever we are having pulsatile release, then it is going to show positive action. Right? What about this leptin? Remember, there is another question based on this leptin. We will be discussing about that, right? So this leptin is going to be responsible for it is going to play permissive role in puberty. Right? So what is going to happen? Let me make you understand. Just give me 2 minutes. So what is going to happen? This leptin is going to responsible for the permissive role in the puberty. It is going to tell us about the adequate fat storage. It is going to tell us about what, Vache? It is going to tell us about the adequate fat storage. So I'm just giving you a simple story. What is going to happen? Suppose there is a 12 or 10-year-old girl. Now she is getting fat. She is eating too much of food. She is getting fat. What is going to happen? She will be releasing what? Her body will be having adequate fat storage, and her body will be having adequate fat storage means what? It will be releasing what? Leptin. And this leptin is going to inhibit a thing that is going to be your kisspeptin. this is going to activate kisspeptin, and this kisspeptin is going to be responsible for the inhibition of GABA. It is going to inhibit GABA, and now what is going to happen? This GABA will be inhibited, and you will be having what? Pulsatile release of GnRH. Pulsatile release of GnRH, and this pulsatile release of GnRH is going to release what? LH and FSH, and this LH and FSH are going to responsible for the puberty. So you must be thinking, normally why we are not having puberty at the age of 5 or 4? These hormones are already present, LH, FSH, and this GnRH is present, but remember, it is not in the pulsatile manner. Whenever it is coming in the pulsatile manner, after sometimes after an interval of like 90 minutes, what is going to happen? This is going to show a positive effect, and this is going to cause puberty. If the baby is more fat, you understand this, if the baby is like a 7-year-old 6-year or 5-year-old boy, and he is having adequate fat storage because he is eating too much of junk, what is going to happen? He will be fat, he will be having more leptin. More leptin will lead to what? Precocious puberty. This person can have precocious puberty, right? This person can have precocious puberty, and if this particular cycle is not working, that particular person can have delayed puberty as well. You understand this? What is the role of this leptin? This is your previous year question. They ask you what is the function of this leptin. Leptin is going to tell us about the adequate fat storage, not us, but it is going to tell the GnRH, so that it can release the GnRH in pulsatile manner, and you can have puberty, right? So this is how it is happening, right? Let's discuss about the male internal genital organs that we are having. So we are having this particular thing. This is going to be your testes. This is going to be your testes, and testes will be releasing the sperm, and the sperm will be coming to this epididymis for the maturation. This testes will be releasing the sperm will be coming to the epididymis. The sperm formation occurs in the seminiferous tubule. Remember, sperm formation is occurring in the formation. If I talk about the formation, let me write the important questions. The formation is happening at the level of seminiferous tubule. Seminiferous tubule. Right now, this sperm, whenever required, the sperm will be going to this particular epididymis for the maturation. What is the function of epididymis? Epididymis function will be maturation. Epididymis function will be maturation, and after the maturation, the sperm, whenever required, is going to go through the vas deferens. This particular is vas deferens, and it will be going here. It will be going here, and here you are having, this is your bladder. This is going to be your bladder, because sperm and urine in male genital organ, there will be single opening, so both the things will be coming out through urethra. Now this sperm is going to come from the vas deferens, right? We are having two glands. One is your seminal gland, second one is your epididymis. These two glands are going to release their substances. This is going to release the seminal fluid, and this is your prostate, which is also going to release the prostatic fluid, and now everything will be coming out through this, right? This is known as semen. Earlier it was sperm. Sperm is coming from the testes, and when it is mixed with the seminal fluid, it is mixed with the prostatic fluid, it is going to become what? It is going to become semen, right? Semen analysis, there will be question. Semen analysis, there will be question. You will be having tests like Barbados, you will be having Florence, right? FMD, very, very important. We'll be discussing about that as well, right? So this is going to be the pathway, complete pathway, and through here the sperm will be going out, and it is going to be responsible for the production of new babies, right? So this is going to be the question, and what is going to be your answer? Testosterone is secreted from which cells? Testosterone is secreted from the Leydig cells. Leydig cells. Wonderful, guys. Which of the following is the dominant motility in the GIT? Which of the following is the dominant motility in the GIT? Next question for you. Yes. Dominant motility in the GIT. What is this MMC? What is this peristalsis? What is this mass movement and segmentation? So migratory motor complex is the motility. You must have known about this particular thing, like you are sitting for a long time in the class, and then you will be feeling hungry. After sometimes, what is going to happen? You will be having a voice coming from your stomach, and you will be thinking like you are hungry. So that is nothing but your migratory motor complex. It is nothing. It is your broomstick of your GIT. It is also known as broomstick of your GIT. It is going to do this cleaning process. It is going to do the cleaning process. तो क्या होता है, whenever you are hungry for such a like 2 3 4 hours, what is going to happen, you are going to have a strong wave of contraction, starting from where, starting from the mid part of the stomach, mid part of the stomach to terminal ileum, mid part of the stomach, this is your question, to terminal ileum. This is going to start from the mid part of the stomach and it will be going to the terminal ileum. It will be doing what? It is a strong wave of contraction. It will be doing this safai, right? But basically it is responsible for the cleaning of your GIT. Whatever food particles are there, they are going to get washed off with the this particular migratory motor complex. So this is not a very dominant motility. All of you think about this, right? I know most of you will be answering peristalsis, and examiner is also knowing the peristalsis, right? So this question do not have the answer of peristalsis, right? I know most of you are going to mark peristalsis, but let me make it clear. Peristalsis is not the answer. Why? What is that peristalsis? Peristalsis means it is going to be a forward movement of the food. So whatever, suppose I'm eating rasgulla, what is going to happen with the rasgulla? Sir, it will be always going in the forward direction. This is what is peristalsis, and peristalsis has a very high speed. So what is going to happen if I'm eating something, it is going downward always. This is your peristalsis. What is reverse peristalsis? And vomiting, you will be having reverse peristalsis. You will be having dilatation of the esophageal sphincter. Everything will be, there will be increase in intra-abdominal pressure. Everything will be contracted. Food will be coming out. This is your reverse peristalsis. So peristalsis is not the answer. Let me make you understand. What is this mass movement? Mass movement is the urge that you are having like 2 to 3 times in a day. You are having for going for the defecation, right? This is known as mass movement. This is going to be a defecation reflex. This is going to be a defecation reflex that you are having, the urge of defecation. This is going to be your mass movement. In children, you are finding that this mass movement will be more, but in adults, you will get used to it. You will understand, you will develop the habit, right? In children, there will be duodenal or gastrocolic reflex. As soon as the mother is feeding the baby, what the baby will do, he will go for the defecation, right? This is what is the problem the babies are having. This is going to be your mass movement, sir. It cannot be the answer. So we have ruled out the 3 option, and now the only one that I have left is going to be your segmentation, right? The only one that I'm going to left is your segmentation. Let me make you understand what is this segmentation, what is this peristalsis. Another question they have asked about the peristalsis. This peristalsis is going to be the proximal, this particular part, the distal part is going to get contracted, whereas this proximal part is going to get dilated. So this is how this bolus is going to always go in the forward direction. So they have asked you the question, they have given the same image, and they have asked you which is the thing that is going to work over here, the point A, which thing is going to work. This forward movement or this contraction is because of what? So let me make you understand. First thing is your acetylcholine that is coming from your parasympathetic nervous system, that is going to be your rest and digest system. Second thing we are going to have is your substance P. Substance P is also responsible for the contraction. Whereas if they now they talk you about the relaxation, so 2 things. First one is your nitric oxide. Remember, nitric oxide for lifetime, it is going to dilate something, right? It is going to increase your cyclic GMP. It is going to dilate something. Apart from nitric oxide, we are having very important VIP, that is going to be your vasointestinal peptides. Vasointestinal peptide, they are also going to do the dilatation, right? So these 2 things are for the dilatation, these 2 things are for the contraction. This is what you should be knowing. Now, very, very important, the dominant motility in your GIT is going to be this. This is going to be your segmentation. This is known as segmentation, right? What is going to happen? So in segmentation, suppose this is the segment which is dilated now. This segment is dilated now. Now what is happening? The same segment is contracting. Again, the same segment is dilating. So what is happening? Regular contraction, dilatation, contraction, dilatation. What is going to happen? There will be breakdown of the food. There will be breakdown of the food, and this is what is digestion, I've told you, right? So this complex food will be going to break down into simple particles, and this is the dominant motility that your GIT is having. Okay, this is the question they have already asked, and again there is a probability they will be asking, because most of you will be marking peristalsis, right? So if you have seen this, you will be marking segmentation from now onwards. You understand what is peristalsis? If peristalsis is going to be very very fast, what is going to happen? The food you are eating, after sometimes 15-20 minutes, it will be going away. This is your peristalsis if it is the dominant one. Okay, but the dominant one we are having is segmentation, right? One more, motility. They have asked a question. This is going to be your basal electrical rhythm. It is because of acetylcholine. Basal electrical rhythm, it is because of acetylcholine. Just remember the things I am telling you. For stomach, you will be having 4 contraction per minute. In stomach, you will be having 4 contraction per minute. In duodenum, you will be having 12 contraction per minute. In duodenum, you will be having 12 contraction per minute. Duodenum. And in your sigmoid, they have already asked you a question on this. Sigmoid, you will be having 6 contraction per minute, right? This is what you need to remember. No nitric oxide and VIP. Sunir, it is going to be responsible for the relaxation. You have studied about the disease achalasia cardia. What is happening? There is no nitric oxide, there is no vasointestinal peptide. What is going to happen? Loss of inhibitory neuron. You will be having sustained contraction. You will be having sustained contraction, and this type of appearance you will be having. This type of appearance is known as bird beak appearance. You will be having problem in the esophageal dilatation, right? Why? Because this nitric oxide and vasointestinal peptides are problematic over there, right? Do you understand this? Next question. Which of the following fiber is responsible for the transmission of slow pain? Which of the following fiber is responsible for the transmission of slow pain? Slow pain. So these are the question from neuropart. Slow pain, fast pain, A delta, A alpha, A beta fibers. They are always asking question on this. So what is the basic funda over here? The basic funda is simple. What you need to remember is the myelination. Simple understanding. Myelination is what? Myelination is done because of sphingomyelin, right? Whenever a nerve is having more myelination, more insulation, more conduction. Simple understanding. Myelination means increase in the speed, faster conduction. Simple understanding, right? So we are having the mnemonic. This is your Erlanger and Gasser classification. This classification is known as Erlanger and Gasser classification. And what is the thing you have to remember? This is the mnemonic you can remember. Prime Minister pressurized to sign the contract fast, right? We are having certain fibers, A alpha, A beta, gamma, delta, B, C. What you need to remember is the diameter. The more the diameter means what? More the myelination. More the diameter means more the myelination. More myelination means faster the conduction, right? So faster conduction velocity with the A alpha, slowest with the C fiber. Slowest with the C fiber. What are the question they will be asking? Proprioception is because of A alpha. Proprioception requires faster conduction velocity. Motor function, it is requiring faster conduction velocity. Pressure and touch, not so fast, but it requires fast, right? That is going to be your A beta. Muscle spindle, that is going to be your A gamma, and delta is responsible for touch, cold temperature, and fast pain. What is this fast pain? This fast pain is important. This fast pain and this slow pain. What is the meaning of fast pain and slow pain? So when you are having an injection of tetanus, what is going to happen? When the doctor is when the person is injecting the syringe, you will be having the first pain. You will be having the pain because of injection. That is going to be your taken up with the help of these fibers. These are your A delta fibers. Then in the night when you are sleeping, you will be having pain. In the next day, you will be having a dull kind of pain. That slow pain or dull kind of pain is because of C type of fibers, because C fibers are slow fibers. Why they are slow? Because they are less myelinated. Simple understanding, right? So A alpha, A delta is responsible for the fast pain. This fast pain is also known as epikratic pain, whereas the slow pain is also known as the slow pain, or this is also called as second pain. This is also known as second pain, and this fast pain is also known as first pain. First pain. Okay, so this is what is important. How they are going to ask you questions? Simple question. They will be asking you which of the fiber is responsible for the slow pain. Now I think you will be able to answer which of the following is responsible for the transmission of slow pain. Or they can give you a case. The patient is having some injury. During the injury he is having pain, and after the injury he is also having the pain. What is that particular thing you will be thinking, right? So this is how they are asking question. Apart from that, they are also asking question based on the susceptibility of the pressure and hypoxia. Remember, A are more susceptible to pressure than B and then C fiber. B and C fiber are concerned with the autonomic nervous system. We do not want a very fast working of the autonomic nervous system, right? So B and C are concerned with the autonomic nerve fibers. Whereas what about hypoxia? The susceptibility to hypoxia, B are more susceptible than A than C, right? Yes, Vinay, Yuga, Sunir, everyone is answering D. Yes, the fibers will be D. What other questions they can ask you? Let me ask you the simple questions. Which of the fiber is responsible for the first pain? Which of the fiber is responsible for the first pain? For the fast pain? For the slow pain? Try to answer wherever you are. Okay, for the motor response, which of the fiber is responsible for the motor response? Which of the fiber will be having highest conduction velocity? Which of the fiber will be having lowest conduction velocity? This type of question they are asking again and again, and this is your Arlinger and Gasser classification. One more you are having, that is Lloyd and Hunt. You can just go through that. Okay, one more is you are having Lloyd and Hunt classification, right? So I hope you will be able to solve this type of question from the neuro part, right? Simple questions they are asking. Now try to solve this question. Which of the following protein is defective in congenital nephrotic syndrome? Which of the following protein is defective in congenital nephrotic syndrome? So we are having certain proteins in the, first of all, let me make you tell me just what is this nephrotic syndrome? What is the meaning of this nephrotic syndrome? What is this nephrons? What is this nephrotic syndrome? Podosin. Remember, we are having basement membrane zone. We are having basement membrane zone, and basement membrane zone will be having certain proteins, right? It will be having certain proteins, right? We are having nephrin, we are having podosin, alpha actinin 4 will be there. Myosin, it cannot be the answer. Myosin is a thick filament. Myosin matlab mota, right? What we have discussed, myosin matlab thick filament. It is responsible for the contraction. Actin, myosin, contraction, right? Actinin is a different thing. So this nephrin is coded by a gene that is going to be your NPHS1 gene. This nephrin is going to be coded by NPHS1 gene, and if there is mutation of this NPHS1 gene, there will be a type of nephrotic syndrome which is known as congenital or Finnish type of nephrotic syndrome. Congenital or Finnish type of nephrotic syndrome. Finnish type of nephrotic syndrome. Congenital or Finnish type of nephrotic syndrome. I'll make you understand what is nephrotic syndrome. Just be with me. Okay. Second, we are having we are having podosin. Podosin is coded by NPHS2. NPHS2. You can remember NPHS1. You can remember first. That is going to be Finnish type, right? NPHS2 is going to cause steroid resistant type of nephrotic syndrome. Steroid resistant type of nephrotic syndrome. Steroid resistant nephrotic syndrome. And if I talk about alpha actinin 4, and if there is mutation of this alpha actinin 4, the patient will be having a specific disease that is going to be your focal segmental glomerulosclerosis. Focal segmental FSGS glomerulosclerosis. Right? So what is this nephrotic syndrome is happening? Simple understanding, let me give you. So what is the simple understanding? We are having, suppose this is your basement membrane. This is your basement membrane. Now what is going to happen in the basement membrane? In the blood, we are having what? We are having cells, we are having plasma, we are having RBC, WBC, platelets. 40% of the cells, 60% will be plasma. That will be having plasma proteins like albumin, globulin, fibrinogen, okay, all this ceruloplasmin, all these plasma proteins will be there, right? Now what is happening? So this plasma protein, suppose I am talking about a glomerular basement membrane. This is your glomerular basement membrane. Here what is happening? Here you will be having this blood will be there. This blood will be having what? Plasma. This blood will be having plasma. this blood will be having plasma, and this plasma will be having what? It will be having waters and it will be having proteins. Plasma will be having plasma proteins. So first understanding is simple. RBC, WBC and platelets are not going to get filtered, right? This is not going to get filtered. Second thing that you should be remembering, what are the things that are going to go away from here? They are going to be small things. They are going to be small things. That means only things like water. Water will be getting absorbed, water will be getting filtered, right? So plasma proteins, plasma will be having water, it is going to get filtered. So your blood will be having water, it is going to get filtered, right? But these plasma proteins, they are big. These plasma proteins, they are big, they are negatively charged, and this particular thing will be having food process of the podocyte will be there, and this particular three things are going to responsible for the formation of food processes of podocytes. These are known as podocytes. They are going to make the species, right? So ultimate function of these things is to not let pass the plasma proteins. What are the plasma proteins? The important one I'm telling you, this is going to be your albumin. तो इनका main function क्या है? इस albumin को बाहर नहीं जाने देना, right? RBC should not go away. So this is the particular main function. ये fenestration, these fenestrations should be very very small, so that only glucose, amino acids, ions and all water should be going out, right? What should not go out? What should not go out? It should not let the plasma protein, it should not let the blood go out. Remember, if you understand this, it is very easy for you. So what is nephrotic syndrome? What is nephritic syndrome? What is nephrotic? What is nephritic? Simple understanding. Nephrotic में क्या होगा? You can remember nephro is like pro. So what will happen? There will be proteinuria. Nephro, you can remember, there will be proteinuria. Proteinuria kitna? More than 3.5 gram per deciliter. That is going to be the proteinuria. What will happen in the nephritic? There will be proteinuria, but less than 3.5. Apart from that, there will be hematuria. There will be hematuria is also going to be there, right? Hematuria is also going to be there. So now what is happening? Nephrotic mein kya hua? Sir, there will be some problem with the membrane. There will be some problem with the membrane. NPHS1 mutation, congenital nephrotic syndrome. What is happening? Sir, this protein is this plasma proteins is going away. This protein is going away. This protein is going away where? In the urine. That is going to cause proteinuria. Now what is the function of this protein? Which is simple understanding. If you make it simple, it will be very very easy for you. So proteins का function क्या होता है? Albumin का function क्या होता है? Blood को thick करके रखना. It will be making the blood thick. Till the time we are having albumin in the blood, what is going to happen? It is not going to go away from the vessels. It is not going to go away from the vessels. Whenever we are having less albumin in the blood, what is going to happen? This blood will be thin. This blood will be thin. There will be less albumin. Suppose these are your albumins. Less albumins, blood will be thick. What is going to happen? The blood will start to leak out. Blood means water will start to leak out from the capillaries, and this water is going to get accumulated in the body, right? So if water is accumulating in the abdominal cavity, what is going to happen? What is going to happen if this water is going to get accumulated in the abdominal cavity, in your lungs, in your legs? What is going to happen? This is going to cause a disease that is going to cause what? That is known as ascites. You understand? So whenever two disease you will be studying, I will be taking the medicine session as well, so I'm just trying to make the base of it, right? So what is going to happen? We are going to have ascites. In ascites, what is happening? Sir, there is problem with the proteinuria. Sir, albumin is going away. Whether it is your liver disease, what is going to happen? Sir, there will be no production of albumin. There will be no production of albumin. If there is no production of albumin, what will happen to the blood? Sir, blood will be thin. Blood will be thin. It will be coming out from the capillaries. It will be getting accumulated in the body. That is going to present with the symptoms of ascites. Now you can understand in the cirrhosis, in the liver failure, in the protein, in the nephrotic syndrome, what is going to happen? The one symptom you already understood. There will be ascites, and the simple story will be, sir, albumin is going away. Albumin, the function is to maintain BCOP, but simple understanding is what? It is going to make the blood thick. It is going to make the blood thick till the time albumin is in the blood. Blood is not going away. Water is not going away. As soon as this albumin will be gone, what is going to happen? This water is going to come and accumulate in the cavity, right? So this is a basic difference between nephrotic and nephritic syndrome. What is the treatment you want to give? You want to give in the treatment part, you want to give what? You want to give Steroids, what is going to happen? Steroid are going to resolve the problem. It is going to heal the membrane. But one more thing I have told you, that is focal segmental glomerulosclerosis. Sclerosis means at a particular focus. Particular focus, what is happening? There is permanent sclerosis. Particular focus, there will be permanent sclerosis. Focal segmental, there is a segment. Focal segmental glomerulo, this is going to be your glomerulus, and this is going to have some sclerosis. And out of this, what is going to happen? This protein is going to go away. Here NPHS2, why it is important? NPHS2, because normally we are giving what, you have studied about nephrotic syndrome. You will be studying about multiple type of syndromes in the pathology, right? What we are giving, most of the cases we are giving steroids. We are giving steroids. Steroids are going to be the first line drug that is going to heal the thing. And what is going to happen? Mostly it will be corrected. But NPHS2 or podosine mutation will lead to steroid resistant type of nephrotic syndrome, and this is what you need to remember. This is what you need to remember, right? So what will be your answer in this particular case? The answer will be option number A. Option number A is going to cause Finnish or congenital type of nephrotic syndrome. You understand this? Okay, so this is the basic story. Now the next question we are having, which of the following lesion can cause dysmetria problem in a patient? What is this dysmetria, Vijay? What is this dysmetria? Dysmetria means there will be some incoordinated movement, or you can say there will be some lack of coordinated movement. Suppose I tell the patient to come and stop here, then he cannot stop here, right? He will be doing whatever things you will be saying, he will be doing overshooting or undershooting. He cannot stop at the particular point. Now the hint is given. What is your answer? Lack of coordinated movement, which is characterized by overshoot or undershoot. Overshoot or undershoot. There will be lack of coordination, which is characterized by overshoot or undershoot. Which of the following thing will be having problem with this type of lesion? Yes, very good, Vinay. Saurabh, very good. Yes. So what you guys think? Let me give you some more options if you try to answer. Right, there will be some other symptoms like ataxia can be there. There will be ataxia. If the patient is trying to speak, he will be having slurred speech. Slurred speech. The patient will be having slurred speech. When you look at the eyes, it will be moving. That is what is nystagmus. Now it is very simple. Everyone try to answer. This is going to be nothing but your cerebellar disease. Cerebellum, you can remember. Bellum का मतलब क्या होता है? It is concerned with the balance. It is concerned with the balance. Cerebellum is concerned with the balance. Get the you need to understand the balance, right? So this is concerned with the balance, and first thing you will be having what? Overshoot or undershoot. You will be having overshoot or undershoot in this particular case. Slurred speech, nystagmus, these are all the symptoms, right? What about the superior colliculus? Remember, it is concerned with which pathway? We have discussed this particular thing in the vision pathway. Yes, vision pathway. So this is superior colliculus is concerned with the vision pathway, whereas this inferior colliculus we have seen in the auditory pathway, ecolaima, mnemonic, auditory pathway, ecolaima. So just go through the sensory part, right? Basal ganglia, you can have multiple things in the basal ganglia. You can have chorea. You can have symptoms of chorea. If they have given you the symptoms of chorea, you will be thinking in the terms of problem lies in the caudate nucleus. The problem lies in the caudate nucleus. And one question they have asked you, let me write it for you, jot down for you. Caudate nucleus, if they talk about, this is going to be your chorea. And the question they have asked you is hemibellismus. Hemibellismus. If the patient is having hemibellismus, what is the site of the injury in the basal ganglia? Remember, it is going to be your subthalamic nuclei. Subthalamic nuclei. Subthalamic nuclei injury will present with the hemibellismus. What is hemibellismus? There will be sudden contraction, sudden voluntary contraction of a large joint. That is known as hemibellismus. You can make a note. Sudden violent contraction, sudden contraction of a large joint. This is going to be your hemiplegismus, right? So in this particular scenario, the answer, I would like to go with the cerebellum. The answer will be cerebellum. Dysmetria is a problem you will be finding with the cerebellar disease, right? Next question in the list, we are having a 22-year-old male patient. He's presented to hospital with the symptoms of epigastric pain, and on further examination, there is excess of release of acid in the GIT. All of the agents increase the gastric acid secretions except. So this is your INI set exam question, exact question they have asked you, and this question is also repeated in a different format, but this question is repeated in NEET PG. So there is a high probability they will be asking you what are the factors. Simple question, if I want to ask you, what are the factors that are going to increase the gastric acid secretion, and what are the factors which are going to decrease the gastric acid secretion? Now I want my answers. Please try to give your inputs. This patient is having what? This patient is having epigastric pain. So simple understanding, if I give you epigastric pain, patient should be what is the differential diagnosis that you should be having in the mind? First thing, it can be GERD, it can be acidity, it can be multiple things, but the main important diagnosis, you should be having differential diagnosis, that is going to be your myocardial infarction. You need to get it done, your ECG, you need to check for the ST elevation, ST depression, and if it is a flat line, then you will be thinking if there is no signs of myocardial infarction, then you will be treating the acidity, right? So this is the thing. Why there is a question mark? Remember for lifetime two things. One, nitric oxide, always vasodilatory. Second thing, somatostatin, always inhibitory. Jahan bhi aayega, whenever this somatostatin is going to come, it is going to inhibit. Most of the things it will be inhibiting, right? We have discussed in the GIT section. In the pancreas itself, alpha beta cells will be making what? Alpha is making glucagon, beta is making what? Insulin. Now what is the function of this delta cells? It is going to release somatostatin, and this somatostatin is going to block alpha and beta, both of the cells. In the brain, it is going to inhibit your growth hormone. Here also it is going to do the inhibitory changes. So let me make a schematic diagram for you. So suppose this is going to be your GIT, this is going to be your parietal cell, and parietal cells will be having proton pump. Parietal cells will be having which pump? Proton pump. And remember three factors which are going to increase this particular thing. First is your acetylcholine. Second is your histamine. Histamine will be having 4 receptor, 2 H2. H1 is concerned with the allergy, H2 is here. Okay. So and third thing is going to come from the G cells. G cells will be releasing what? G cells will be releasing gastrin, and this gastrin is also going to activate the GIT. It is going to activate the parietal cell. This is your parietal cell, and this parietal cell is going to make what? It is going to make HCl. It is going to release, proton pump is going to release H plus, and it is going to bind with the chloride bicarb extension is there, and it is going to make what? HCl. Now the simple story, what is this somatostatin is going to do? This somatostatin, remember, this somatostatin is going to inhibit the gastrin. It is going to inhibit the gastrin, and whenever it is going to inhibit the gastrin, what is going to happen? There will be decrease in the acid, and this is what they are asking. They want to know which is the thing that is going to decrease in the levels of acid, right? You understand this? This type of question you cannot afford to make it wrong. If you are having issue, let me give you simple basic understanding. So whenever you are eating something, what is going to happen? You are going to have these three things. These three things are going to increase the acid. Remember, this gastrin, histamine, and acetylcholine are responsible for increase in the HCl production, whereas this somatostatin is responsible for the decrease in HCl production. Apart from this somatostatin, there will be negative feedback. Apart from this somatostatin, there will be negative feedback. Whenever there is more acid, it will be automatically inhibited, right? These two things at least you should be remembering, right? Now, how these things are going to activate your acid, let me make you understand this. Okay, so whenever you are having, food, whenever you are having food, you are going to have activation of your parasympathetic nervous system, and we already know parasympathetic is concerned with rest and digest. And what is the neurotransmitter of parasympathetic nervous system? That is going to be, sir, acetylcholine. And this acetylcholine is going to go to your parietal cell. This acetylcholine is going to go to your parietal cell, and it is going to make what? It is going to make HCl, which is going to be responsible for the digestion, right? So we are having this M1 receptor, M3 receptor, and they are going to activate your acetylcholine. Second thing, this histamine is also going to get activated. The drug that is going to block this histamine is going to be your Rentic. I'm just giving you a quick review, right? The drug which are going to block this acetylcholine are your prenzapine, talenzapine, right? And this gastrin is going to get released whenever you are having food in the GIT. This gastrin levels will increase, and this gastrin is responsible for making what? HCl. This gastrin is responsible for making HCl, right? If there is a tumor of this gastrin, what is the thing that we call it? We call it, if there is a tumor of G cell tumor, we call it G cell tumor, that is known as Zollinger-Ellison syndrome. We call it gastrinoma, G cell gastrinoma. Gastrinoma matlab tumor, right? So we call it gastrinoma, G cell tumor. And what is going to happen? You will be having lots and lots of gastrin. Lots of gastrin will be releasing what? It is going to release lots and lots of HCl. Lots and lots of HCl. Another tumor, let me make you understand. We are having type A, B, and C gastritis. So type B gastritis is due to bacteria. That is a bacteria, Helicobacter pylori. What this bacteria is going to cause? It can cause cancer in the patient. It can also cause cancer. It can cause gastric adenocarcinoma. It can cause gastric adenocarcinoma. Adeno क्यों बोला? Because gland है, right? Adeno gland के cancer को बोलते हैं, right? Next thing, it can cause another tumor that is known as maltoma, mucosal associated T cell lymphoma. So देखो, there is a simple bacterial infection and it can cause cancer in the patient. So we have to be very, very careful whenever this patient, whenever any patient is having H. pylori infection, we need to treat this H. pylori. You know what this H. pylori is going to do? If you want to understand the mechanism, it is going to block the D cell. It is going to inhibit the D cell, and remember, these D cells are releasing what? Somatostatin. These D cells are releasing what? Somatostatin. And if there is decrease in the somatostatin, what is going to happen? There will be no break on the gastrin. This is going to inhibit what? Gastrin. This is going to inhibit gastrin. So there will be decrease in the somatostatin, there will be increase in the gastrin, and this gastrin is going to cause what? Increase in the levels of HCl, right? And this is the HCl which is going to be responsible for the ulcer, and this ulcer will be having certain there will be transduction, basically lysogenic convergence, and it can cause cancer. It can cause cancers like maltoma and adenocarcinoma. Okay, so for the treatment we are having like triple therapy and quadruple therapy. You will be studying in the pharmacology. Triple therapy, quadruple therapy, you will be studying there, right? So we need to treat this particular thing, right? So my thing is, what we need to do, we need to understand what is the thing that is going to decrease the levels of acid. This is a simple question they have asked in INICET Center Institute examination. So if this type of question will get repeated in FMG examination, I hope you will be marking it correct, right? So the answer will be somatostatin, universal inhibitor. Anytime you will be having somatostatin, it is going to inhibit. The mechanism of action I have already told you, right? The next in the list, we are having question number 22. A 26-year-old male patient is sent for cholecystectomy under general anesthesia. This patient is going under general anesthesia for cholecystectomy. Maybe he is having some stones in the, maybe he is having cholelithiasis. So during the anesthesia, the patient starts hyperventilating. Patient is hyperventilating, and the value of EtCO2, expired CO2, is alarmingly high. And how we can check? We can check with the help of capnography. We are having certain graphs we will be discussing in anesthesia. Which of the mutation can be responsible for this particular thing? Yes, Mohammed, we will be giving triple therapy. Triple therapy will be having CAP. You can remember CAP: C for clarithrol, A for amoxi, and P for any kind of PPI we will be giving, right? So CAP therapy. quadruple, we will be adding some bismuth subsalicyclate, or you can add sacralfate, right? This is what you will be studying in pharmacology, right? So what you need to remember, what is the diagnosis over here? What is your diagnosis? Very, very important thing. There are only few things in anesthesia that can be asked, like emergency things, right? And the reason is in the physiology. So let me make you understand how this thing is happening and what is this. This is known as, the diagnosis is what? Diagnosis, guys. What is your diagnosis? What do you suspect this patient is having? एक patient है, वो anesthesia के लिए गया है. We have given certain drugs. Maybe we are giving succinylcholine. Maybe we are giving halothane, any kind of inhalational agent, halothane, iso, sevoflurane, desflurane, anything we are giving. This can precipitate this particular disease, right? So most common with the succinylcholine and another inhalational agents, right? So like halo, sevo, isodes, this is what we are commonly using. So we are giving our patient this particular thing, and this patient is having, wonderful guys, you are giving me the answer. So this patient is having the diagnosis, this patient is having malignant hyperthermia. Is there any malignancy over here? No, this is not a malignancy. It is a deadly situation that we are having. It is an emergency situation, but nothing like malignant. Okay, so this is going to be your malignant hyperthermia. And why this thing is happening? What is the gene that is going to be responsible for this malignant hyperthermia? Sorry, what is the gene that is responsible? What is the thing? Is it going to be because of DHPR? Is it going to be because of RYR or SERCA or neuromuscular junctions? So let me make you understand how this thing is happening, right? How this thing is happening. So whenever, suppose I want to contract this muscle, for the contraction, what I need to do, I need to think about it, right? I will be thinking about it. The information from my brain will be going till here. The information from my brain will be going till here, and then what will happen here? Certain neurotransmitters will be coming, and it will be producing some contraction because of actin and myosin, right? You understand this? So how this conduction is happening, and now we are looking at a nerve muscle junction. So this is a nerve that we are having, and here we are having synapse, and this is going to be your muscle. Let's understand this. This is going to be your muscle. So how the impulse is traveling? Yesterday in the last class I have discussed how this impulse is traveling from one box to another, one cell to another. There will be depolarization, repolarization again, right? So this is going to be the first thing. Second thing that I want you to understand, there are certain diseases that you will be studying, right? One is your malignant hyperthermia, I have told you. One is your myasthenia gravis. One is your Lambert-Eaton syndrome. We will be discussing in the medicine, right? So what is going to happen? Whenever the sodium is going to come inside a cell, whenever a positive charge is going to come inside a cell, what is going to happen? This cell is going to get depolarized, right? What is going to happen? This is going to get depolarized, and because of depolarization, what will happen? Calcium channel will open, and this calcium will be coming inside. This calcium will be coming inside. If you follow me, you understand the complete story. Calcium has three function. One is it is going to cause vasoconstriction in the vessel. It is going to cause muscle contraction whenever it is going to the muscle. And third thing, it is going to cause exocytosis. It is going to cause exocytosis. So what is happening over here? We are having acetylcholine vesicles. Vesicles will be there. As soon as this calcium is coming inside, this vesicle will be going out. This vesicle will be going out because calcium is coming inside. So what is happening? This vesicles will be releasing what? Acetylcholine. Now we are having what? Acetylcholine over here. And this is the acetylcholinesterase, which is going to break it down. Okay, you can connect it with the pharmacology as well. Right now, this acetylcholine will be having certain receptors. It will be having certain receptor. It will be having muscarinic receptor. It will be having nicotinic receptor. And muscarinic we will be discussing in the ANS, M1, M3, M5, M2, M4. And nicotinic we will be having neuronal. Nicotinic receptor will be neuronal and neuromuscular, right? So we are discussing about the neuromuscular thing now, right? We are discussing about the neuromuscular thing, and if there is problem with this particular thing, at neuromuscular junction, what is going to happen? You will be having a disease that is going to be myasthenia gravis. That is going to be your myasthenia gravis. So neuromuscular junction problems, that is going to be myasthenia gravis. If this calcium will be not able to enter inside, is it going to be possible that acetylcholine is going to go away? No. This type of problem is known as Lambert-Eaton syndrome. Lambert-Eaton syndrome. These two things we will be discussing, right? Lambert-Eaton syndrome. Just maybe you can go through your notes so that you can understand, right? So this is going to be your Lambert-Eaton syndrome. This is going to be your myasthenia gravis. Both the things are happening at this particular level. Now, if normally this thing is happening, what is going to happen? So acetylcholine is going to come to the muscle. It is going to cause certain conformational changes in the muscle, and it is going to produce contraction because of actin and myosin. Sarcomere will be coming together. Two sarcomere will be coming together, and it is going to cause contraction. But for contraction also, remember, calcium is needed, right? So how this calcium is going to come? Remember, because of acetylcholine there will be depolarization of because of sodium. Acetylcholine is coming, it is going to release sodium, and sodium is going to cause depolarization, and because of this depolarization, next question, there will be a receptor that is known as dihydropyridine receptor. Two things will be there, dihydropyridine receptor, and it is going to bind with the ryanodine receptor. It is going to bind with the ryanodine receptor. The question they have asked in the exam, this type of coupling is not electrical coupling, it is a electromechanical, and if only mechanical is in the option, you can go for that as well, because in the exam there was only mechanical coupling. So there will be very less space, around 15 nanometers, so they can do the mechanical coupling. What kind of changes it will be there? There will be mechanical coupling will be there. And what is going to happen whenever these two things are going to bind together? It will activate your sarcoplasmic reticulum, and we already know sarcoplasmic reticulum will be having increased levels of it will be having calcium. The sarcoplasmic reticulum will be having calcium. This is sarcoplasmic reticulum, and it will be having storage of calcium. And now this calcium will be coming into the muscle, and this calcium is responsible for the sliding filament theory that you are having, and you will be having what? Calcium in the muscle. It is going to cause contraction. It is going to cause contraction. This is the basic story, and there will be this calcium will not be staying here for such a long time, so this calcium needs to be taken back, and taking back of this calcium is because of a pump, that is sarcoplasmic endoplasmic reticulum calcium ATPase. very very important thing. सरका पंप इज देयर. सरका का काम क्या होता है? ये जो भी कैल्शियम बाहर गया है उसको वापस से अंदर लेके आएगा. दैट इज व्हाट इज सरका पंप. एंड दिस पर्टिकुलर cycle is also happening in your heart. The drug that you are giving, like digoxin, is going to work like that only, right? So you can connect it there, right? This is the function of sarka. So sarka, you already understood what is the function of dihydropyridine receptor. It is going to bind with the ryanodine receptor, and ryanodine receptor dihydropyridine is going to lead to increase in the calcium. They are going to increase calcium. Calcium is going to be responsible for the contraction, and all the calcium will be taken up by the sarka. Neuromuscular junction, if we have discussed, if there is mutation, there will be myasthenia gravis. If there is problem with the this calcium channel, that is going to be your Lambert-Eaton syndrome, right? What will happen? What is the answer over here? The answer is, whenever there is mutation in the ryanodine receptor, whenever there is mutation in the ryanodine receptor, there will be this particular disease. Ryanodine receptor mutation can lead to malignant syndrome. Normally it is not happening, but if the patient is having exposure, to succinylcholine, patient is having exposure to any inhalational agent, you will be having a syndrome, malignant hyperthermia. There will be malignant hyperthermia, right? And for the treatment you are giving dantrolene, right? And this patient will be having what problems? What is malignant hyperthermia? Sir, there will be excess of calcium will be released, and excess of calcium will lead to what? Excess of calcium will lead to excess of contraction. Excess of calcium will lead to excess of contraction, and there will be lots of contraction in the body. Every muscle in the body is getting contracted. What will happen? There will be increased metabolism. Metabolism is what? Sum of anabolism plus catabolism. All the reactions that are happening in your body, they are going to be metabolism. So whenever there is going to be increased metabolism, there will be increase in CO2 production, and that is what you are seeing on the screen. That is going to be your increased EtCO2. That would be leading to your that particular graph, right? So what you need to do, you need to block that calcium, you need to decrease the calcium. Otherwise what will happen, because of contraction there will be vessels. In the vessels, what is going to happen, there will be vasoconstriction. In the cells, what is going to happen, in the nerve cells, what is going to happen, there will be exocytosis, right? So this is a deadly condition. What we need to do, we need to decrease the calcium release. And what is the drug of choice? That is going to be your IV sodium tentrolene. You understand the complete thing about this particular topic, right? Very good. I'm getting the right answers, right? Okay, so the next question in the list, we are having question number 23. We are having tyrosine is a precursor molecule for which of the following neurotransmitter? Tyrosine is a precursor molecule for which of the following neurotransmitter? Only two more questions are left. Stick with me. Tyrosine is a precursor molecule for which of the following neurotransmitter? So what are these neurotransmitter we are having? We are having serotonin, we are having glycine, acetylcholine, dopamine. So what do you think, dopamine, what is the neurotransmitter that is coming? Okay, Vinay, very good. That is going to be D. So first of all, let me make you what is this neurotransmitter, and the question they have asked you, this neurotransmitter are going to form where? They are going to form in the cell body, and with the help of which protein they have asked the question? That is going to be with the help of ribonuclear protein. With the help of ribonuclear protein. In the option they have written RNPs, ribonuclear protein. So this is what you need to remember. What is cell body? So if this is a neuron, this is going to be cell body, this is going to be axon, and then there will be synapse, and here you will be having what? All the dendrites that you will be having over here, right? So here you will be having cell body, and all this neurotransmitter are getting synthesized here itself, right? So this is the first thing that you have to remember. Apart from that, what is the function of this serotonin, glycine, acetylcholine, or dopamine, and what is this tyrosine is going to do? Remember this tyrosine, if I want to talk about this tyrosine is present in your black coffee, right? You guys are taking black coffee or green tea. So what is not green tea, black coffee or tea or something like that. So what is going to happen in your fat cutter drinks? So what is happening, this tyrosine is responsible for the production of T3 and T4. And this T3 and T4, you already know, this is a thyroid hormone. So it is going to make what? Thyroid hormone is going to do what? It is going to make thyroid, and thyroid has a function, it will increase the metabolism. So this tea or black coffee the people are taking before gym are going to be working like that. Apart from that, it is going to increase your epinephrine, norepinephrine, and dopamine. It is going to synthesize epinephrine, norepinephrine, dopamine, right? This epinephrine, norepinephrine, dopamine, they are going to be the neurotransmitter for sympathetic nervous system, and sympathetic is always concerned with fight or flight. It is going to be the nervous system which is going to be very, very fast, right? It is going to activate your BP and all those things, right? So this is going to increase that. Apart from that, it is also responsible for the production of melanin. They have also asked this question, right? And this melanin is responsible for giving the color, right? That is why your grandmother is always telling, don't drink too much of tea or coffee, otherwise you will get black, right? So this is also giving color, melanin, or it is also giving the color. She knows about it, right? Next we are having wonderful Shahnawaz, you know everything, right? Okay, so what is going to happen? What are the other things we are having? We are having glycine, acetylcholine, dopamine. Let's try to understand. First thing, you already understood that this is going to make the dopamine. Remember dopamine, you have always studied about dopamine. What are the different pathways we are having of dopamine? Remember dopamine has 4 pathways, 4 important that you have to remember. Like we are having mesocortical pathway, we are having mesolimbic pathway, we are having tuberoinfundibular pathway, right? And we are having nigrostriatal pathway. So when we talk about nigrostriatal, the disease will be in dopamine decrease in the nigrostriatal pathway. What is going to be the disease? You always discuss about dopamine, but it has different function at different places. That is how we are using different drug at different places, right? So you must be wondering about it, right? So when this dopamine is decreased in the nigrostriatal pathway, we are going to have a disease that is going to be your Parkinson. when it is going to decrease in the tuberoinfundibular pathway, it is also known as dopamine, has another name that is known as prolactin inhibiting hormone. Dopamine is also known as prolactin inhibiting hormone, and it has a function to decrease prolactin, and prolactin function is to product is the production of the milk, right? So what is going to happen? So this is going to be decreasing the prolactin, right? Mesolimbic and mesocorticals. Mesocortical is responsible for the negative symptoms in psychiatry. You can remember NMC, right? So negative symptoms in psychiatry that you are having, like anhedonia, apathy, avoliation, asociality, right? All these negative symptoms will be there. Mesolimbic is concerned with the positive symptoms. What are those positive symptoms we are having? We are having delusion, illusion. So all these positive symptoms we'll be discussing in detail in psychiatry, right? But now you can remember dopamine has multiple pathways and it will be having different functioning, right? So whenever there is increase in dopamine, we call it mania. So we want to decrease dopamine here. In nigrostriatal pathway, patient is having symptoms of Parkinsonism, we are giving dopamine, levodopa, carbidopa, right? So you can understand like that, right? So now we are having the neurotransmitter table, and we will be going basically short things. Anhedonia is we will be discussing in the psychiatry. It will be the patient will be having problem with the those things that were those people who are having getting the pleasure from something. For example, I watch movies and I feel good in the past, but right now what is happening, I am not feeling that good after watching the movies. So those activities which were previously pleasurable, that were giving you the pleasure, right now they are not you're not feeling good with that, right? So this is what is anhedonia. Okay, right. Next one we are having is acetylcholine. What is this acetylcholine? Acetylcholine is the neurotransmitter of parasympathetic nervous system. The disease, it will be having two receptor. We have seen nicotinic and muscarinic receptor, and the disease you will be having is what? You will be having decrease in the levels of acetylcholine in one more disease, that is going to be Alzheimer. Alzheimer, what is going to happen? Decrease acetylcholine, okay, in nucleus basalis of Maynard, right? Decrease in the acetylcholine. Second thing, what about this serotonin? The serotonin is going to be responsible for the sleep. It is going to be responsible for the sleep, mood, and appetite. Mood disorders, you must have studied about the mood disorders, like we are having depression, right? So most of the antidepressant that we are using, most of the antidepressant drugs that we are using, they are going to elevate your serotonin. Like we are having SSRI, selective serotonin reuptake inhibitors. We are having drugs like SNRI, serotonin norepinephrine reuptake inhibitor. So basically we are just trying to increase the serotonin. We are trying to increase the 5-HT, right? We are trying to increase the 5-HT. Okay, this serotonin we want to increase. We are using in the cases of antidepressant drugs as well. What about this dopamine? This dopamine we have seen. So it is going to be coming out from the hypothalamus. Parkinson, if they are talking about, now you will be telling me, they want to talk about Parkinson, which pathway they are talking about, which pathway they are talking about. If they are talking about the Parkinson, which pathway? SNRI will be duloxetine and venlafaxine. This fluoxetine, all these things will be SSRI. Okay, norepinephrine, you can already simply you can remember, it is coming out from the adrenal medulla, adrenal cortex and medulla. We have seen cortex will be having mineralocorticoid, glucocorticoid, and sex steroids, right? So GFR, three layers we have seen: glomerulosa, fasciculata, reticularis. What about this medulla? These are the part of the cortex. Glomerulosa, fasciculata, reticularis, these are the part of the cortex. What about this medulla? Medulla will be having release of what? Medulla will be releasing catecholamines. The things that are coming from medulla, they are known as catecholamines, and it will be producing what? It will be making dopamine, and dopamine is going to be responsible for the production of this particular thing, norepinephrine, right? So these are your catecholamines like adrenaline, noradrenaline, and dopamine. These are going to be coming out from the adrenal gland, right? This levodopa is going to be the precursor of dopamine. Tryptophan is going to be the precursor of serotonin. This is the question they have asked you. Levodopa is going to be precursor of dopamine, right? Next thing, what about this GABA? What about this GABA? GABA is always going to be inhibitory. We are going to have this GABA. GABA is always going to inhibit the CNS. It is always going to inhibit the CNS. We are having drugs that you are using, GABA mimetic and GABA facilitatory. Mimetics will be your barbiturates, and that one, second one is your facilitatory, is your facilitatory will be your benzodiazepines. Benzodiazepines group of drugs like clonazepam, all these drugs, they are going to decrease the activity of the brain. They are going to increase the GABA. This is what we want in the cases of epilepsy, in the cases of whenever the patient is having hyperactivity of the brain, right? So we want to decrease it. This is going to be your GABA, benzodiazepines. What about this glycine? Remember this glycine we have seen, and one more poisoning we will be discussing in this subject of FMT. We will be discussing about a poisoning, that is going to be your strychnine poisoning. Strychnine poisoning is going to work on the this particular glycine in the spinal cord, and now you can very well appreciate that what is going to happen in the tetanus also, it is going to inhibit the inhibitory neurons. So what is going to happen, there will be sustained contraction, right? Same story is happening at the level of strychnine poisoning. One seed is a fatal dose. So what is going to happen, this patient is going to have inhibition, and because of that inhibition, this patient is again going to have sustained contraction, and this is going to give you which posture? My dear students, tell me which posture? Yes, that is going to cause you opisthotonous posture, opisthotonous, or bow-like posturing, or opisthotonous posture, right? The styramine is metabolized by MAO, and you will be having this this tyramine. MAO is going to be responsible for that, and you are having a disease that is cheese reaction. So we are avoiding the cheese, and the drug you will be using is phentolamine, right? Glutamate is responsible for the long-term potentiation of the memory. Very important thing. Long-term potentiation of memory is happening at the level of hippocampus. So when you are sleeping, simple understanding, you guys are studying right now, you guys are studying is important, but we have discussed in our classes, in full classes, how important is the sleep. The exam is coming nearby. You can compromise on anything, but don't compromise on your sleep, because when you are sleeping, whatever you are studying throughout the day, it will be getting converted into your basically your temporary memory is going to get converted into long-term memory, right? So sleeping is very important. Don't skip on your sleep, right? 7 to 8 hours of sleep is something that all of you should be having, right? Apart from that, whatever other time you are having, try to save time over there. Don't compromise on your sleep. You are sleeping for 4 hours, that will ultimately decrease your output. It will decrease your output. You will be not be able to retain the things. Sleep well, eat well, take care of yourself. Dengue is happening all around, right? You have to take care of the diseases as well, because if you are getting ill at this point of time, it will take a lot of your time. You will be having anxiety, you will be having issues. So please take care of yourself, and just try to eat good food, just try to have good sleep and good study. That is what should be the agenda for the next 1.5 to 2 months, right? And just go through the sessions, and you just revise the notes. That is what you should be doing at this point of time, okay? So this is the glutamate, which is going to be responsible for the long-term potentiation of the memory, and it is going to work via NMDA receptor. One more question I want to address over here. This is the ketamine is going to block this NMDA receptor. So you can make a note over here. So it is a it is a question that has been asked like in last month examination, NEET PG exam, INISET examination, right? So you should be remembering this. So this is what is about the dopamine. This is what is about the dopamine. You understand what is this tyrosine is going to do, why people are taking black coffee now? I think you will be understanding, because it is going to activate your sympathetic nervous system. All the fat cutter drinks will be having this particular thing, right? T3, T4, that is going to increase your thyroid, and thyroid is responsible for the metabolism. Patient is coming, she is having thyroid, uh, she will be a patient with thick patient. She is not she is having cold intolerance, right? Why these things she will be complaining, I'm not able to eat the food, I'm not able to I'm just not eating anything, I'm just only drinking water, still I'm getting fat. So these are all the symptoms of hypothyroidism, right? Okay, next thing. Yes, yes Mohammed, yes Mohammed, yes Kajal. right? So now we will be discussing about the concentration of which of the following is maximally decreased in the PCT. Next question that you are having, we will discuss about that in the later part moment. I'm glad you guys are liking it. It is helping you. This is for the students, like you guys are the most important thing. Wonderful, right? So let's come back to the thing, the question that we are having in front of us. We are having concentration of which of the following is going to be maximally decreased in the PCT. So first of all, let me make you understand just what is this PCT, what is this whole nephron is all about. So just understand the simple basic story. I want to give you the story, right? I believe when you connect factual information with the story, it is going to retain for a longer period of time in your brain. So that is why I'm just trying to give you the story. So what is that cardiac output, which is the cardiac output I've told you is going to be your heart rate into stroke volume. Heart rate into stroke volume, in the question I have already explained, stroke volume will be end diastolic minus end systolic. So that would be coming around as 70 out of 120. There will be 70 going away, 50 will be staying there. That is what we have discussed. Let's say the heart rate will be 72 or 75. What is going to happen? The ultimately cardiac output will be 5 liter. So I believe in a minute your heart is pumping 5 liter of blood. Out of that 5 liter, just listen to my story, out of that 5 liter, 20% will be going to the kidney. So that is going to be 1 liter. Out of 5 liter, 20% will be going to the kidney. That is going to be your 1 liter. And out of that 1 liter, you will be having 40% will be cells and 60% will be plasma, right? 40% cells, these are your RBC, WBC, platelets. So they are not going to filter. We have discussed it through the basement membrane, right? We have discussed the 60% will be going away, and this 60% is what? This 60% is going to be plasma. So can I call it 600 ml? Out of that 1 liter, 60% will be 600 ml. So 600 ml of blood is going to the kidney, and this is known as renal blood flow. This is known as renal blood flow. In the question they have asked, we can assess this renal blood flow with the help of para-aminohippuric acid, right? Out of this 600 ml, only 20% is going to get filtered, bache. Only 20% is going to get filtered. And what is the 20% of 600? 60 plus 60, that is going to be your approximately 120 ml per minute. And this is what is you guys are calling GFR. This is what is your glomerular filtration rate. This is what is GFR, and the dye we are using is going to be your inulin. The dye that we are using is going to be your inulin, right? Now out of that 120 ml, what is the normal urine output? If I want to talk about normal urine output in a day, that is going to be 1.5 liter. That is going to be 1500 ml. Everyone is passing around 1 to 2 liter. So that is going to be average 1.5 liter. In a day, we are having approximately 1440 minutes, right? So can I say every minute 1 ml urine is getting formed? Try to understand this. Can I say every minute there is 1 ml of urine is getting formed? So every minute 1 ml of urine is getting formed, 1 ml per minute. And what about this 119 ml? It is going to get reabsorbed. It is going to get reabsorbed. This is your GFR, glomerular filtration rate. So let me make you understand over here. So this is going to be your heart, and this is going to be the blood which is going. This is afferent, that is going to bring the blood. This is going to be efferent, that is going to take the blood away. E for exit, A for anevola, in Hindi you can remember. So whatever blood is coming from the heart, that is going to be your 5 liter. This is the function of kidney excretion and filtration of blood, right? So what is going to happen? Whatever blood is getting filtered over here, I have taught you about the basement membrane. Whatever is getting filtered over here, this is known as glomerular filtration rate. And sir, how much is that? How much is that? That is going to be, let's say, 120 to 125 ml per liter. So you can remember approximate values for the ease of the understanding, right? So it will be 120 ml is going to come over here, and out of that 120, can you appreciate this part is proximal and it is convoluted? Yes, it is a proximal part, it is a convoluted part. Can I call it proximal convoluted tubule? Yes, it is a proximal convoluted tubule. Then this is going to be your loop of Henle. This is a hairpin like structure. This is going to be thick part, here also thick part, then thin part, then thick part, then thin part. Okay, so you will be having thick ascending limb of loop of Henle. This is a part which is a distal part, and it is also convoluted. So can I call it distal convoluted tubule? Yes, it is distal part and convoluted, and it is going to drain all the urine into the collecting duct. I've taught you about the collecting duct, two cells. Upper part will be principal cells, lower part we are discussing about the antidiuretic hormone, right? So ultimately what is going to happen, you are going to have those two urethras, those two ureters will be coming out, and those two ureters will be draining the blood, draining the urine directly into the bladder. And remember, I have already shown you the bladder. After that bladder, what is going to come, that is going to be your urethra, and this urine is going to come out. And how much is the urine that is going to come out? That is going to be, we have already discussed about that in the cystometrogram, how this urine is getting filled, what is that Laplace law. We have already discussed about that in this particular video, right? So this is going to be the urine output, and this urine which is coming from your heart, it is going to go to your urinal, it is going to go away from your body, right? And this urine which is going away, you can remember, you always studied about oligouria, polyuria. What is that oligouria? When do we call it oligouria? When do we call it polyuria? What is that oligouria and polyuria? I want your response. Try to answer. I'm not going into detail, just giving you the rough information so that you can remember. First question, they have asked you, what is the thing that you should be knowing about the PCT? Remember, PCT will be responsible for 100%, around approximately, let me make you understand, 65% of the salt and water is going to get reabsorbed over here, right? 25% is going to get reabsorbed over here in the loop of Henle. 6 to 8% is going to get reabsorbed in the DCT, and 2 to 3 is going to be responsible in the collecting duct. So this is how most of the fluid will be getting reabsorbed. Okay. Apart from that, the drugs that you are studying, PCT, you will be having carbonic anhydrase inhibitor, acetazolamide. You are going to utilize loop diuretics over loop of Henle, right? Here in DCT, you will be discussing about the thiazides. Here you will be discussing about the spironolactone, eplerenone, trimethoprim, all these drugs, right? And here you will be discussing about the two drugs. One is in the diabetes insipidus, that is going to be desmopressin. Second one, that is going to be your thiazides. Okay, and in the second thing that you are having increase in the levels of ADH, that is going to be a SIADH, and the drugs you will be using is coniveptan. So this is a short quick summary that I'm giving you. What happens about the this particular thing in the PCT? Remember, PCT is going to be responsible for the absorption of 100% of the glucose, 100% of the amino acid. So 100% of glucose and 100% of amino acid is going to get reabsorbed from the PCT. Normally, you can think like that. Normal people, we are having normal people. If I'm going out for a urination, what is going to happen? Am I going to pass the glucose in the urine? No, I'm not going to pass, because what is going to happen, my body is going to reabsorb the glucose from the kidney. What is the pump that we are having here? This is a question. This is going to be your SGLT2. SGLT1 is also there, but you can remember 2 is also there, right? 2 is maximally present. And this SGLT2 blocker, name the drug that you are giving, SGLT2 blocker, right? And what will happen? What is the cutoff value? Cutoff value is also asked in your NEET PG examination, so you should be knowing. So this is going to be, if your kidney is getting 375 milligram per deciliter of blood, what is going to happen? Your kidney will be absorbing all the blood. Your kidney will be absorbing all the glucose. If it is going 375 milligram, your kidney will be absorbing all the glucose, and that is corresponding to which value? That is going to be your 180 milligram per deciliter, right? If your blood glucose is 180, till that particular time everything will be getting reabsorbed. But if you are having glucose of 300, what is going to happen? This pump is not going to work, and the extra glucose will be going out through the urine, and that is what is going to be glycosuria. That is what is going to be glycosuria. Okay, and this is what we are doing in the cases of diabetes. SGLT2 is not gliptins, bache. SGLT2 inhibitors are gliflozins. Canagliflozin, you can remember like that. Gli means glucose flows in urine, that is going to be your gliflozin. Canagliflozin, dapagliflozin, that is going to be your Gliflozin, dapagliflozin is going to be your this particular thing. Okay. Active transport, yes, it is a type of active transport. What active? Primary active or secondary active? Remember, SGLT2 is a co-transporter. It is a type of secondary active transport. Secondary active transport. So whenever I'm just giving you the trick, the trick is whenever you are finding in the question co-transporter, symporter, antiport, okay, exchanger, if this type of terms are given, you can mark the answer as secondary active transport. This is also important question they are asking again and again. So if this type of thing is written, you can go for the secondary active transport. What about the other things, like your proton pump? It is going to be primary active transport. Okay, sodium potassium ATPase pump, it is going to be primary active transport, right? So this is how you will be going for that, right? So the answer here in this particular question will be answer number C. Is that okay? No issues with this. The next question, we are having a group of 10 students went on a trip to mountain. The BP of a person is rising and they don't have any medication. So this is a history, right? You guys are going for a trip and you are having no drugs, right? So you are a doctor but you do not have the drug, right? So they don't have any medication. They try to decrease the BP. How you will decrease the BP as a doctor? You will try to decrease the BP by doing a massage. And what is that kind of massage? That is nothing but your carotid massage. I've specified this is a carotid massage. Carotid massage they are doing, and carotid massage will activate the parasympathetic nervous system, and parasympathetic has a simple function. It is going to increase or decrease the BP. It will increase or decrease the BP, let me know. Okay, so all of the following are the neurotransmitter of, this is a wrong thing, all of the following are the neurotransmitter of sympathetic nervous system except. So they want to know about the neurotransmitter of parasympathetic. So you already know these all three are together known as catecholamines. They are known as catecholamines. They are all known as catecholamines, and catecholamines are going to be responsible for increase in the BP, whereas acetylcholine is going to be decreasing the blood pressure. It is going to decrease the blood pressure. If you understand this, fine. If you don't understand this, I'm just giving you a very short and quick summary, right? So we are having parasympathetic nervous system, we are having sympathetic nervous system. Sympathetic and parasympathetic. Sympathetic is concerned with fight or flight, right? Parasympathetic is concerned with rest and digest. If you want to see in detail, you can watch the other video. I've covered it in detail, right? So it is going to be responsible for the rest and digest, and this is going to be the neurotransmitter here. Parasympathetic neurotransmitter acetylcholine. Sympathetic neurotransmitter will be noradrenaline, adrenaline, and dopamine. So these are going to be the basic thing. What are the receptors we are having? We are having muscarinic receptor, we are having nicotinic receptor here. Muscarinic, I've told you, we are having M1, M3, M5, M2, and M4 receptor, and they are going to be GQ type of subunits. So they are going to cause the contraction. Contraction of M1 will lead to contraction of CNS, that is going to increase the cognition. M3 is going to present, you can remember like that, we are having eyes, then we are having mouth. Mouth will be having, we are having eyes, we are having salivary gland, we are having bronchus, we are having GIT, we are having we are having bladder. So all these smooth muscles are innervated by sympathetic parasympathetic nervous system. M2 is present at two places, that is going to be your SA node and AV node, right? So they are all going to get contracted. There will be increase in the contraction. When this M2 and M4 are going to get contracted, this is going to be a GI or G0 subunit. So they are going to produce relaxation. Simple story, if you are smoking, what is going to happen to your body? When you are smoking, you will be inhaling nicotine. This nicotine is going to increase your cognition. It is going to increase your filtration of the brain, right? Second thing, filtration of brain means you are, whatever you are saying with the filter, nothing like that, filtration, right? Second thing, when it is going to it is going to activate your GQ subunit. It is going to cause contraction of the pupil, that is going to be meiosis. that is going to be meiosis. So any sympathetic drug, any parasympathetic drug is going to cause the same thing, like in the cases of organophosphate poisoning. Same symptoms will be there. What will happen to the salivary gland, sir? It will also contract. GQ means calcium, calcium means contraction. Salivary gland contraction will lead to increase in salivation. Bronchus contraction, bronchoconstriction. GIT contraction, what will happen? You will be having increase in the peristalsis. That is why people are taking smoking cigarettes in the morning, right? What will happen to the bladder? It is going to get contract. Bladder is also going to get contract. And what will happen to the SA node and AV node? SA node is concerned with heart rate, so it will decrease the heart rate, decrease the palpitations. And AV node is going to be responsible for the conduction, so it is going to decrease the conduction, right? So this is the basic functioning of the parasympathetic nervous system. Anticholinergic, you will be studying in the pharmacology, right? What is the basic functioning of sympathetic nervous system? So you are going to have alpha 1, alpha 2, beta 1, beta 2, beta 3. These are going to be receptors. Basic functioning: alpha 1 is going to cause vasoconstriction. It is going to contract the it is going to do the vasoconstriction. Alpha 2, it is going to acting as a brake. Beta 1 receptor are present at two places. One is your heart. In heart it will be present in your SA node, AV node and muscles. दिल में कुछ नहीं है. The only three things we are having दिल में, ठीक है? We are having SA node, we are having AV node, we are having muscle. Nothing apart from that, right? Second thing, we are having what? We are having kidneys. We are having kidneys, and in kidneys we are having what? Renin. Second thing that we are having is renin. Beta 2 is present on the bronchus, and it is going to cause bronchodilation, and beta 3 is going to present at two places. One is on your adipocyte and second one is your bladder and adipocytes, right? So this is going to be the basic understanding. Whenever you are having increase in the levels of any catecholamines, like as adrenaline, noradrenaline, dopamine, what is going to happen? They are going to activate alpha 1. Alpha 1 is going to cause vasoconstriction. Vasoconstriction will lead to increase in the BP. Alpha 2 acting as a brake. This SA node is activated. What will happen to the heart rate? Increase in the heart rate. AV node is activated, increase in the conduction. AV is always concerned with the atria and ventricular, that is concerned with the conduction. And muscle is activated, there will be muscle contraction. What will happen to the bronchus? Beta 2 agonist drugs like your salbutamol, everything is going to cause bronchodilation. Beta 3 is going to be responsible for the it will be present on the bladder and adipocytes. It will be acting with the HSL, and it is going to cause adipolysis, or basically lipolysis, you can understand, right? And this renin is going to activate your renin angiotensin aldosterone system, and the ultimate function of RAS, it is going to activate your aldosterone. It is going to increase the BP. Aldosterone is going to do vasoconstriction, leading to increase in the BP. It is going to retain salt and water. That is going to lead to increase in the fluid in the body. If fluid will be increased in the body, what will happen? Blood pressure will be increased, right? So this is what is the basic functioning of the parasympathetic and sympathetic nervous system that you should be remembering, the neurotransmitter and the basic functioning that we are discussing, right? With this thing, we are done with the session. I've tried to cover most of the important things for you. In future we will be having more such sessions, right? Don't worry about that. Just try to revise the things that we have discussed, right? Apart from that, don't look for multiple PDFs. Just whatever notes or whatever set of notes you are having, just go through that. Whatever extra important information you are finding, just try to add on to that particular notebook. Okay, don't make multiple notebook, don't run for multiple sources. Just stick to your source and just try to enhance it and try to solve the questions. Okay, the positive thought for today: nobody can go back and start a new beginning, but anyone can start today and make a new ending. So we are having still a lot of days in our hand, and it is truly possible even to achieve more than 200 marks even if you are starting at this point of time. So don't worry about that, be positive, and everything will fall on the place, right? These are my Instagram and Telegram. I'll share the PDF. Don't worry about the PDF. I'll share in the group. You can join the group and you can get the PDF. Okay, thank you. Pleasure is all mine. Thank you, guys. See you in the next session. We will be doing 6 to 7 more subjects I would be covering. So don't worry about that. We will be meeting on the next sessions.